Hello, I'm Jan Lichtman.
Hi, I'm Gayatri from Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. David Bernstein. Dr. Bernstein is the NYACP District President of Nassau East, the treasurer of the Empire Liver Foundation, the treasurer of the Bacchus International Society of Gastroenterology, and the former director of the Sandra Atlas Bass Center for Liver Diseases at Northwell Health.
In today's presentation, Dr. Bernstein discusses the most recent advancements in the diagnosis and management of non-alcoholic fatty liver disease.
Did you know that Dr. Bernstein is an internationally renowned researcher who has directed more than 200 clinical trials in all phases of development, founded and built the Hepatology department in Northwell Health, and has multiple appointments on the New York Department of Health, including member of the HCV Elimination Task Force and Hepatitis C Advisory Council at the New York State Department of Health. Is also on the Chicana, New York State Hepatitis C member advisor for hepatitis C and the lead physician of the ECHO project for New York State, has been recognized amongst Castle Conley's best doctors in New York, a recipient of multiple honors, including the American Cancer Society's Doctors of Distinction honoree and the Physician of the Year award from the American Liver Foundation.
What an accomplished and inspirational leader in the field of gastroenterology.
So let's tune in. Let's tune in and learn from this global leader.
If we talk about non-alcoholic fatty liver disease, and this is data from the United States, non-alcoholic fatty liver disease is the most common chronic liver disease in the US. It's moved up the ladder to become the second most common reason for liver transplantation in the United States after alcohol. Unfortunately, it has become the leading predisposing factor for the development of primary liver cancer. And this cancer can occur even in the absence of cirrhosis, which really makes it quite worrisome, since I'll show you the numbers of people in the US who have this disease. And then the majority of patients with fatty liver disease have normal liver enzymes. So if you don't think about it, and if you don't assess, you're going to miss it in the majority of people. And again, the majority of people, because of that, remain undiagnosed, not only in the US, but around the world. So if we look at what the numbers are, and we just talk about fatty liver, which encompasses all people that have fatty liver, and I'll begin to explain the differences. It's 1 in 3 Americans. So the estimate is to be about 110 million people. The United States has a population of roughly 330 million people. As we go down a disease spectrum, about 20 million folks will have non-alcoholic steatohepatitis or NASH. And here's where we begin to become concerned about these patients, because once they have inflammation, once they have scarring, then they become at risk for the development of liver cancer and all the complications of liver disease, including cirrhosis. So I guess the good news is the majority of people just have fatty liver and won't be a problem, but still about a fifth of the patients will go on to develop significant disease called NASH. And then if we take one step further down, as you can see here, there are estimated to be between 4 and 5 million people in the United States that have bridging fibrosis or cirrhosis secondary to fatty liver. So that's a big number. That dwarfs all other causes of liver disease combined, which lead to cirrhosis in the United States, as far as we're aware. And these are the folks that are at risk for liver failure, complications of advanced liver disease, encephalopathy, variceal bleeding, ascites, and the dreaded hepatocellular carcinoma. And so this is the population that we're really trying to address. The number of people who have the disease, as you see, are quite large. And there's a significant unmet need, not only in how we evaluate patients, but how we treat patients and just what to do with them. Because the sheer volume of patients overwhelms many of the practitioners that we currently have. If we look at the natural history then of fatty liver disease, and you can see that here, people are born with a normal liver. The progression of this condition is then You go from a normal liver to fat, which is the non-alcohol fatty liver. You see that as NAFL. Then patients can progress to NASH that we talked about, with or without fibrosis. And those patients are at risk for developing cirrhosis and all of its complications. How long does it take then to go from just fat to fat and inflammation and scarring to cirrhosis? And we really don't know that good answer because we don't have long-term natural history studies. But we're beginning to believe that patients can progress every 5 to 7 years from fatty liver to these complications if they're going to progress. Since the majority of patients now are really being diagnosed when they're 20, 30, and 40 years of age, you're talking about a very large number of people who are going to have significant liver disease still at a young age. And then if we follow down to the bottom of this, which shows patients who can develop hepatocellular carcinoma, you can see that whether someone has fatty liver, inflammation and some mild fibrosis, or cirrhosis, all are at risk for developing hepatocellular carcinoma. The incidence do vary. So in non-cirrhotic patients, the incidence is very low. It's about 0.1% per year. Whereas those that have cirrhosis, it's 1 to 2% a year. But having said that, 30 to 50% of patients who develop liver cancer from fatty liver do not have cirrhosis. And so we have yet to figure out how to best screen these patients and how to best advise these patients to be evaluated for liver cancer. What are the risk factors? There are many risk factors for fatty liver disease, but the two biggest risk factors are having diabetes or being obese. And much of the United States and much of the world are obese. There are multiple other risk factors. I'm really not going to list them all, but you should know there are special groups, those with hypertension, those with dyslipidemia, so the high cholesterol, high triglyceride population, and another subset that have polycystic ovarian syndrome. These aren't all of the risk factors for fatty liver. And if you're going to really pay attention to the ones that are most important, it's diabetes and obesity. And as many as 50 to 70% of patients with type 2 diabetes have fatty liver, which is why it's so critical for our endocrinology colleagues to be aware of this, look for it, diagnose it, and quite frankly, treat it. What is the prevalence then amongst an obese population of fatty liver and NASH? 70% of folks who are obese have fatty liver. About 30% will have NASH. So you're talking about a tremendous number of people. And the predictions are, and 2030 used to be far away, but it's not so far away anymore, that almost 50% of the adults in the United States by 2030 are going to be obese. And if you follow the slides that the CDC has, you can follow all 50 states, and they change color over time over the past 20 years. And there are no states that don't have at least 30% of the population being significantly obese today. And so we are really preparing for, as best we can, an epidemic of advanced liver disease 1 to 2 decades from now. And if we're smart, and if we can figure out therapies and get people to pay attention to this, perhaps we can prevent all the complications that are now being predicted, because there aren't enough caregivers to care for folks. We do know that a Western diet and a Western lifestyle is associated with weight gain and obesity, and then fatty liver. And there are tremendous variations across the globe, but there isn't a single country and a single continent that has not seen a rise of fatty liver disease. As an aside, the country that's seen the greatest rise in diabetes and fatty liver disease is China. And so we're just seeing it. The area of the world which has the greatest prevalence of fatty liver disease is the Persian Gulf and the countries in that area. So it's not just the United States This is a worldwide problem that is only getting worse. And I show this because this literally came out this week in Clinical Gastro and Hepatology. And this is an article on the effect of fatty liver disease on pediatric diabetes. So approximately 900 children with a mean age of 12 years of old, mostly boys, were followed for about 13 years to see what happened to them as regards to the development of diabetes. The mean BMI was 31, so they are all obese by definition. 17% of these patients, while still children or very young adults, developed type 2 diabetes. That's one in 6 children. So there's an epidemic of diabetes. And we're going to see it more and more since so many of our young kids are overweight. Who is at greatest risk for the development of type 2 diabetes with fatty liver? It was actually the women. So the girls. And so it's going to be important to intervene early. And this study is fairly large. And it shows us that the incidence of type 2 diabetes in children with fatty liver disease is actually 30 times greater than that has been previously reported. So this is a real problem. So if you say that the kids are now getting diabetes at 20, 25, they have fatty liver, you can predict that by 35, 40, they're going to have not only potential complications of diabetes, if not well controlled, but they're going to have significant problems with advanced liver disease. So this is something that we need to act upon sooner than later. Right? Having said that, there's another condition which is a little concerning, and that condition is called lean fatty liver or lean NASH. Lean meaning that they are developing fatty liver and NASH with normal body weights. And so these are thin people that are developing fatty liver. And this subset of fatty liver disease has a worse prognosis than those people who are actually overweight. And so how do we define lean NASH? In non-Asian adults, we define lean NASH as occurring with a BMI of less than 25. And in Asian adults, we define lean NASH as fatty liver occurring in people whose BMI is less than 23. Now, I'll say straight away, we don't know the pathogenesis of fatty liver. So why do thin people develop this? Why do people who are overweight develop this? We just don't know. There's a lot of research being done, and there are more unanswered questions than questions we're actually able to answer. So right now, most of the data we have is observational, but there's a tremendous amount of work being done. If we look at the overall prevalence then of lean NASH, and this comes from a couple of studies about 2 years ago, the prevalence of lean NASH in patients with fatty liver disease is about 18 to 20%, so almost a fifth. The prevalence of lean NAFLD in all people is 4 to 5%. So think about how many people live on Earth and how many people are thin and how common this is. And amongst thin people, still about 10% are going to have fatty liver. So we are looking at significant concerns for health in the not too distant future. Lean NASH has a cardiometabolic rate that's similar to fatty liver in obese people. Patients with obesity and fatty liver are at significant risk for the metabolic syndrome, hypertension, diabetes, and dyslipidemia. Well, so are those with lean NASH, right? And so you can see that here. 50% of them have elevated lipids, a third with metabolic syndrome, a little more than a third with hypertension, and 12% have type 2 diabetes. So it's a problem. And if we then look at the probability of developing complications in NASH by BMI, you can see there in the top right the patients with lean NASH, when compared to those who are overweight or obese who have NASH, are at a greater risk of developing a cardiovascular event. So thin people with fatty liver are more likely to have a cardiovascular event, whether that be a myocardial infarction or a stroke. If we look at the other parameters, cirrhosis and the development of cancer, well, those that are overweight or obese are more likely to actually then develop that. And there's no difference over time in when these complications occur, whether someone is thin, overweight, or obese. And so, once again, lean NASH is very important to be identified. So I just laid out a picture for you of fatty liver disease, which is so common. And so the question really then to be asked is, should we be screening for this? Well, nobody's really quite sure. So here are some guidelines or recommendations from some societies around the world. The American Association for the Study of Liver Disease says no screening, but maintain a high suspicion if patients are diabetic. The Europeans, which is the middle, say that patients with obesity and metabolic syndrome should be screened with liver enzymes and sonogram. And those that are high risk, more than 50 years of age, with cardiovascular disease and or diabetes, should also be screened. The American Diabetic Association, much more proactive, and they recommend that anyone with type 2 diabetes or pre-diabetes with an elevated ALT, remembering that a normal ALT in a woman is 25, upper limit of normal, and a man 35, should be screened for NASH and for fibrosis. And if found, treatment should be initiated. So we're just getting these recommendations, from our societies. I think the AASLD has a long way to go, quite frankly, in their recommendations. How do patients present? Well, most are asymptomatic. They feel fine, and they're discovered really by chance, right? Usually it's an incidental finding, mildly elevated ALT, mildly elevated alkaline phosphatase, sonogram done for another reason, where there's a question of fatty liver, or on physical exam or imaging, that the liver is large. But having said that, the majority of people have normal liver tests and have no symptoms, right? So how do you find it, right? And if you find it, how do you then assess the disease severity, in these patients? And can you do that in 1/3 of people living in the United States? Well, we use simple non-invasive tests right now. We do not do a lot of liver biopsy in these patients. The simple tests are the NAFLD fibrosis score, which I'll show you, which you can calculate on your own. The fibrosis 4 test or FIB4 test, which is probably the most used test, but you can also calculate on your own. And I stress calculating on your own because if you go to the middle, you can see the proprietary test, which you can order, FibroSure, FibroSpect, or Enhanced Liver Fibrosis Test, or ELF. These are costly and really don't add much more than the simple test other than the ELF test, which is actually quite good. And on the right, we use imaging, transient elastography or MRI. Two types of tests that are readily available. MRI is expensive, not in all communities, but transient elastography is beginning, at least in the United States, to become more available. The reality is we usually use a simple test and some type of imaging test and put the two together, because two tests are always better than one in this type of situation. The NAFLD fibrosis score has 7 parameters: age, AST, ALT, platelet count, BMI, albumin, and whether or not the patient has fasting glucose, impaired fasting glucose, or is diabetic. And you plug it into the computer or your smartphone, and it will give you a number. And it's very good at determining if someone has no fibrosis or significant fibrosis. In the middle, not so good. The FIB4 does the same thing, but only uses 4 parameters: platelet count, ALT, AST, and age. And you get the same thing. If the number is low, less than 1.3, pretty much rules out fibrosis. If the number is high, more than 2.67, these patients are likely to have bridging fibrosis or cirrhosis. But again, in the middle, none of these tests are actually good. So we talk about imaging. And how do we image? And how does imaging help us in patients with fatty liver? So fatty liver disease can be diagnosed on imaging. You can see it on sonogram with increased echogenicity. You can see a big liver, and you can see low attenuation when compared to the spleen. NASH cannot be diagnosed by imaging because NASH is inflammation, and there are certain parameters that need to be defined, and NASH can only be diagnosed then by biopsy. You can get a CAT scan, and you will see low attenuation of the liver when compared to the spleen. But it's expensive to do a CAT scan, and a CAT scan has radiation. So we really don't use CAT scan much in these patients. Many of these patients are diagnosed by CAT scan because the CAT scan is done for another reason, and then they say, oh, look, the patient has fatty liver. So you can find fatty liver, but you can't find NASH. Transient elastography, of which there are several types, I'm going to show you one, which is FibroScan, is a simple test. It's non-invasive. It can be done in the office. It requires a 4-hour fast, well, where you can't have any liquids or foods beforehand. Not that you can't technically do it, you can, but if someone eats and or drinks, what happens in the body is blood flow gets shunted towards the liver, and that increased blood flow after eating is going to cause the machine to read more scarring than is actually there. There's a code for this. There are special probes, whether someone is obese or not, so you need to have the different probes. And this can be performed by a non-radiologist, a gastroenterologist, a hepatologist, an endocrinologist, a primary care office if they're interested in, since it is reimbursed. And then we use parameters. You know, we get what's called the KPA. And if it's low, less than 6, there's no scarring. If it's 12 or above, there's cirrhosis. And then we can also say moderate or severe based upon the other numbers. And you can follow this serially. And we see all the time someone gains weight, the numbers go up. Someone loses weight, the numbers go down, which tells you that fatty liver and fibrosis is a dynamic, not a static process. You can get better from this. And, you know, that's very important, especially for patients. You have to be careful not to overestimate. So you have to know when you can use this or not. So again, non-fasting doesn't work. In patients that come in with acute hepatitis, because the numbers are so high, you're going to get increased readings of scarring. Same thing if there's congestion from congestive heart failure or if there happens to be a lesion. But this is a really easy, simple test to determine how much scarring is present. And so we use it always in combination with the FIB4 because we can calculate because we have those already. MRI elastography, even better because it gives you a picture of the whole liver, but it's expensive. And people have to go into an MRI machine. You can see on the left an example of no fibrosis. And you can see on the right someone that has significant fibrosis, and you can see all of that red. And so, very good test. We use this a lot when there's a discordance between the FibroScan imaging or the transient elastography and the blood test like the FIB4. And then MR elastography, very useful for us. So we talked about how you can diagnose fatty liver. How do you actually diagnose NASH? And unfortunately, in 2022, the only way to diagnose NASH is to do a liver biopsy. There is no other way. And when you do a liver biopsy, you can see inflammation, you can see apoptosis, you can see things that are all consistent with NASH. But the question we have to ask ourselves is, do we have to do a biopsy on everyone with fatty liver disease? As a hepatologist, surprisingly, I'll argue that the answer is no, because we don't have treatments for people yet. But if we're not sure what's going on, then we should do a biopsy and see. And we will be seeing more and more biopsies being done. Now, there's a concept being worked on now that's called a liquid biopsy. Liquid biopsy is actually parameters used from the blood. And there's a tremendous amount of research now looking for diagnostic parameters for NASH and also for liver cancer that you can find in the blood. So you're going to be hearing more and more, and you read the literature about a term called liquid biopsy. But for now, the only way to diagnose NASH is a solid biopsy. You actually have to biopsy the patient's liver to be able to do that. And this is complicated, but this is really good for the primary care person. How do you then assess NASH? Well, we talked about the biomarkers and the FIB4 or the NAFL fibrosis test. We talked about imaging, and then we talked about sort of putting them together, right? This is very helpful because if you see someone with fatty liver, you do a FIB4 and there's no scarring, you can follow that patient. Repeat the test in a year, 2 years. Discuss with them about treatment, which right now is behavioral modification. If there is significant scarring, that patient needs a referral to a specialist and needs confirmatory tests with imaging, most likely transient elastography or MRE. And if there's any question, you do a biopsy. So it's a fairly simple algorithm that you can follow. And now most of these tests are available all over the place, quite honestly. So now let's move to treatment. How do we treat fatty liver? And first, we really treat everyone with fatty liver, but there are specific goals for those patients that have NASH. Remember, that's the group that already has shown that they have inflammation and fibrosis. So the goals of the treatment are to improve metabolic abnormalities, decrease inflammation. How do you tell that? Well, we use ALT as a surrogate marker. Prevent, stop, or reverse liver fibrosis. We can do that by assessing with a fibroscan. And most importantly, to prevent disease progression such that you can prevent the development of liver failure, cirrhosis, liver cancer, and all of those related outcomes. So how do we do that in 2022? So here are some of the things that we have in our armamentarium. The top left is the most important, right? And it's lifestyle modification, diet, exercise, and weight loss. We can talk about using anti-hyperglycemic agents like a GLP-1, and we can even consider bariatric surgery as we try to control obesity, because we know if you lose weight, fatty liver gets better. We can target NASH in the bottom right with liver-directed treatments, which are all off-label. There's nothing approved for the treatment of fatty liver in the United States. And we can use things like vitamin E or pioglitazone. We certainly need to discuss with patients about reducing cardiovascular disease risk, since the most common reason why people die with fatty liver are cardiovascular disease, not liver disease. So you need to treat hyperglycemia, you need to treat hypertension, you need to treat dyslipidemia. And so statins become very useful. And it's important to note that it's perfectly safe to use statins in patients with liver disease, even those that have cirrhosis. So there was a large study years ago from the Dallas Heart, more than 10,000 patients. Statins are safe in patients with liver disease. They should be used. And in fatty liver, you're going to see some good responses in the patients who are taking statins. So I talked about first-line therapy being lifestyle. You need to cut out what you eat, right? Decrease caloric intake with a goal of losing weight of about 7 to 10% of your total body weight, and I'll show you that. Drink a lot of coffee. Coffee has actually been shown to be liver protective. 2, 3, 4, 5 cups, and you're actually going to do well and may prevent the development of advanced liver disease. Look at a good diet, low to moderate in fat, some carbohydrates, and I'll talk about what diets people can take. Avoid anything with fructose. All the snacks you can buy in the supermarket, all of the sodas that have fructose. Fructose is horrible and probably the one chemical that's the worst for anyone with fatty liver disease. Really strictly follow alcohol intake. Men should drink no more than 30 grams a day, women 20 grams a day. And you can see here some examples. I would say that it should really be much, much lower than that. But these are the current recommendations worldwide. And then physical activity is critical. You need to exercise at least 3 to 5 times a week and do some good aerobic exercise. But exercise itself won't do it. You need to combine it with diet, and you have to have a result, which is weight loss. So what diet should we recommend? Right, that's the $1 million question. And there's actually been a study, European study, look at the comparing a low-fat diet versus a Mediterranean diet. Patients started with about 25% hepatic fat content. They were watched closely and carefully for 18 months. All of the patients who followed both diets showed a decrease in the amount of hepatic fat content. But you can see that those that followed the Mediterranean diet with low carbs had a significantly greater improvement in their fatty liver and also a significantly greater improvement in their overall cardiovascular risk. So it's this and several other studies that have led us to recommend the Mediterranean diet in patients that have fatty liver, in patients that have diabetes. It's really just a healthy diet, right? It allows you to have pretty much everything, but concentrates on fruits and vegetables, certain pastas and rice, protein via fish or other seafoods, moderate portions of eggs, dairy, and other dairy. And you can still have sweets and meats, but you need to be smart about what you do. You can still have occasional alcohol, but you need to drink a lot of water, right? You need to drink a lot of water, which is very helpful. So if you follow, and this is of all the things I'm going to show you for treatment, this is the most important slide. This says if somebody loses 10% of their body weight, what happens to the complications of fatty liver? So if someone loses 10% of their body weight and have NASH, 90% of them will have NASH resolution. 81% will have regression of fibrosis, not elimination, but regression by at least one stage. And 100% will have an improvement in the amount of fat in the liver. But unfortunately, only 10% of people can lose 10% of their body weight. If you're 200 pounds, you need to lose 20 pounds. And so this is by far and away the most important treatment, weight loss. However you can do it, weight loss will help. So what are the off-label treatments that are available? Vitamin E, recommended 800 international units a day in non-diabetic patients, but you do need to biopsy the patients first and they have to have NASH. Pioglitazone, recommended in patients with and those without type 2 diabetes, but they have to have biopsy-proven NASH. Obeticholic acid, used for primary biliary cholangitis. Good data just released in this patient population in NASH using obeticholic acid, but we still need further data before we can say use it. And although GLP-1s are widely used now in fatty liver, the reality is we do still need further data. GLP-1s are used because patients lose weight. And if they lose weight, their NASH improves. It does make a lot of sense. Right? And then there are a host of, in the US, FDA-approved weight loss medications that you can see here. None of them are approved in fatty liver. But if you lose weight, your fatty liver gets better. So anything that you can do to help patients lose weight will be beneficial to their liver. Patients always want a pill. And, in this case, it's a hard swallow because there isn't a pill. They really need to change lifestyle, and changing lifestyle takes time. If there are other complications, if the patient has advanced fibrosis or cirrhosis, and they're a candidate for bariatric surgery works to eliminate fatty liver, to improve fibrosis, and even to reverse cirrhosis. So bariatric surgery is absolutely an option. The most common operation currently being used is a sleeve gastrectomy. It works well. And you can see here a study which showed the regression of fibrosis in patients who had bariatric surgery. They do extraordinarily well. Within 6 months, there's a dramatic decrease in the amount of fibrosis and fatty liver disease. And years out, if the patients don't overeat through the bariatric surgery, they do incredibly well. And here you can see an example of an MR on the left with significant amount of fat and fibrosis prior to bariatric surgery. This is MR. And to the right, you can see 6 months later, the amount of fat has pretty much disappeared, right? And the amount of fibrosis pretty much gone. And so you can see very quick, dramatic results with bariatric surgery in this patient population. So then begs the question, what's next? And we'll just spend a few moments before we finish up on what's next. And I must tell you, there's just a ton of research going on, as you can imagine, because the patient populations are so great. Most have been disappointing, and we really don't have great endpoints. But there are a few products that are investigational that have made it to phase 3, where the phase 3s are still going, or their data is going to be analyzed and released soon. You should expect to see in November at the liver meetings in the US, a lot of data coming out, on these products. And so there's hope. At least we think there's hope. This I alluded to earlier. This is the data that just came out a week ago on obeticholic acid for NASH. This is public data, not in an abstract form or a manuscript form. This is a press release from the company that is sponsoring the trial. But there was a significant improvement in the higher dose of obeticholic acid versus placebo in the main endpoint, which is at least a 1-stage improvement in fibrosis with no worsening of NASH. There was not any significant difference in resolution of NASH. And obeticholic acid, as I'm sure you know, the main side effect is pruritus. So it's fairly common. Patients don't need to have to be stopped for it, but and they can be managed, but it does occur. And there was a trend, it seems, in this initial data for higher rates of biliary events, including gallstones in the patients who received the high dose of obeticholic acid. So more to come, but at least promising. This may be the first drug approved for NASH. I don't know. But it's certainly the one that's most far along in its development. And then there are a whole host, and this is not inclusive of all, but there are a whole host of other investigational products in phase 2, and there are a lot in phase 1. So you should expect to see significant data in the next several years on fatty liver disease and its treatment. But at the end of the day, it's really mostly diet, exercise, and weight loss in combination with these things. Patients want a magic pill, but a magic pill isn't going to exist. You're going to need to have lifestyle modifications. And so how do we manage these patients? If you see on the left, those who are low risk, those who have fatty liver without scarring, they can be pretty much managed by their primary care doctors, or their endocrinologists, or their cardiologists. They need to be told about lifestyle intervention. They certainly will benefit from weight loss program. trials or vitamin E, pioglitazone, not recommended, but there needs to be discussions on cardiovascular disease risk reduction. Those patients on the right with high risk, bridging fibrosis, cirrhosis, they need to be seen by a liver doctor and managed by a multidisciplinary team. They need intervention as far as lifestyle. They need to be sent to a structured weight loss program, be placed on anti-obesity medications, consider bariatric surgery. They may be candidates for vitamin E or pioglitazone. And again, you need to have discussions about cardiovascular risk reduction. And if they're diabetic, the preferred medications are pioglitazone or GLP-1s. And so we're beginning to develop recommended algorithms for treatment. So I'm going to conclude with a couple of overall statements regarding best practice in the treatment of fatty liver disease or evaluation of. Lifestyle modification using diet and exercise to achieve weight loss is benefit for all. Among patients with NASH, ideally you want to have them lose 10% of their body weight, which can result in significant progression of fibrosis. If you're going to talk to them regarding a diet, you should really target a 1,200 to 1,500 kilocalorie diet per day with a 30% reduction at least from what they had been taking before. If you're going to recommend a diet, the Mediterranean diet is the way to go. A low-calorie diet can also be implemented for patients with lean NASH with a lower target of weight loss because they're thin to begin with, somewhere between 3 to 5%. You should absolutely recommend exercise. And patients should have vigorous exercise at least 3 to 5 times a week, but it needs to be combined with diet so that you see the effect. Patients with fatty liver disease should be evaluated regularly for other potential coexisting metabolic conditions, diabetes, hypertension, cardiovascular disease, and those conditions should be managed aggressively. And alcohol consumption should be restricted or eliminated from the diets of patients with fatty liver disease. You don't really want to have two diseases going on. And just to be timely, because this also came out this week, everyone's discussing COVID. What is the actual effect of COVID on patients with fatty liver disease? And here, at least we have a bit of good news. Patients with fatty liver disease are not at any increased risk of developing severe COVID. So obviously these patients should be vaccinated and boosted. However, they are not at increased risk because of their fatty liver disease of developing severe COVID. So I just like to throw that in at the end. And with that, I'm going to stop. Thank you for attention.